The gravity of the time is such that every new avenue of peace, no matter how dimly discernible, should be explored. Never before in history has so much hope for so many people been gathered together in a single organization. You will provide a great share of the wisdom, of the courage, and the faith which can bring to this world lasting peace for all nations and happiness and well-being for all men.
So we are here today with Dr. Ahmad Ameri, who's a clinical oncologist at the Imam Hossein Hospital in Tehran, Iran. Thank you so much for joining us today.
Thank you. Thank you for inviting me for this interesting discussion about the radiation.
Yes, we're here to
radiation
talk about the amazing work that you're doing. And so I'd love if you could start off by giving us an introduction as to your background and how you entered into this field of study.
Yeah, I'm a radiation oncologist. Now I'm an associated professor in Shahid Beheshti University of Medical Sciences in Tehran and working in the clinical oncology ward of Imam Hossein Hospital. I'm a faculty since 2003, and now I'm associated professor. I also studying medical education now. I'm about to finish it. And my major duty in the university is education for the residents of radiation oncology or clinical oncology. In Iran, radiation oncologists treat cancer with systemic treatment and also radiation. That's why we named it clinical oncologist. And but we also treat patients in private and governmental hospitals. And I also, my interest is head and neck cancer, treating head and neck cancer with chemotherapy, radiotherapy, hormone therapy, immunotherapy nowadays. And but we do also research. But most of research are clinical research for our patients.
Could you maybe tell us what motivated you to become a doctor? Was there in your childhood, did you have a family of doctors? Did you have an interest in medicine? What was the original passion?
My father pressure. My father pressure. My father asked me to be a doctor. I was not interested to medicine. I just started mathematics. In my branch in the school was mathematics, but my father forced me to be a doctor, and I participated in the medical concours and accepted in the Urmia University of Medical Sciences. That was the real reason.
That's probably the same anywhere you go in the world.
But now I'm now I'm happy with this decision.
Yes. Are you going to pressure your kids to become doctors as well?
My son is an intern, and he will finish 1 year later. But he also decide by own, not by my pressure.
Sure he did. And then was there something that drew you, once you became a doctor, was there something that brought you to the field of oncology and treatment of cancer? Why that instead of a different field like orthopedics?
Back into my background about mathematics, I thought that the radiation oncology is a field full of physics and technology. But when I entered the residency, I saw that this is not the technique. It's completely clinical branch, and especially in Iran, because we are involved with the patients from the diagnosis until the death. That's why this was a misconcept about the radiation oncology in Iran. But now I think it's a motivated branch and is very, very high level of education and treatment. You are involved in the technology, decision, and everything that has in the medicine you can have together to help your patients in this good feeling.
Most people that are not in medicine probably don't know much about chemotherapy, about radiation, about cancer treatment at all. And but radiation saves lives. Most people are probably scared of radiation, but how many lives have we saved with radiation?
Yes, you are right. Cancer had treatment, three main treatments. One is the surgery, one is the radiation, and the one is the systemic treatment, including chemotherapy, hormone therapy, and nowadays immunotherapy. But based on the research and based on the international organization, so surgery can cure about 40% of cancer patients. Radiation also cure about 40% to 50% of patients, and systemic therapy cure about 10 to 50% of cancer patients. But most of patients need a combination of these treatments. Consider that some of cancer are local, just local growth, but some of cancer have a propensity to disseminate in the body. That's why we need systemic treatment. And we combine systemic treatment with local treatment to achieve more and more effective treatment for our patients. I think radiation, I think most of people know the cancer with the chemotherapy because of the side effects. All patients are worried about the side effects of treatment. And in cancer treatment, side effects of chemotherapy is more than two others options, including surgery and radiotherapy. That's why when you speak about cancer, all patients bring in mind the hair loss, vomiting, and something like this. Although the chemotherapy just cure 15% of patients. But chemotherapy use drugs. Drugs has a support as the pharmaceutical companies. They support the medicine, they support the chemotherapy drugs. And that's why all patients know cancer with chemotherapy. All studies has been done with chemotherapy. Radiation and surgery has less support, especially radiation, because radiation is the second step in patient management. Most people have the biopsy or then refer for radiation, or had surgery and then refer for radiotherapy. So when you are designing a trial for the radiation, maybe you cannot accrue enough patients for this study. Or nowadays, more study in radiation has been started due to immunotherapy. because it was defined that the radiation with unusual fractionation can increase the effect of immunotherapy. That's why we have more study with radiation. That's because of support of pharmaceutical companies.
But why is that? Why has nobody decided to look at studies just with radiation, or start with radiation before you cut into someone or before you apply chemotherapy to isolate the effectiveness of the radiation?
Because the study need money. Somebody should pay for the study. All studies in the chemotherapy or immunotherapy in hormone therapy were supported by the pharmaceutical company they are rich companies. But for radiation, no. For radiation, there is no support. It's a business that they sell their machines and then support for maintenance, and they can give their benefit. That's why we cannot have the radiation only study. We have, but most of them are supported by the governments or international communities, not by the pharmaceutical companies or by the radiation producing companies, machines, radiation.
Where did you first see the idea to use radiation to fight the cytokine storm, the inflammation due to COVID? Where did you first see this in the world or in publications? How did you know to start conducting studies along these lines?
Yeah. I didn't see at first. Our hospital was the center for COVID patients, and all of wards was full of COVID patients. Neurologic ward, orthopedic, any wards was occupied by a huge number of patients with COVID-19. We was in the very shortage of the human resources and the medical equipments, including ventilators, monitors, and something like this. I think, how can we help them? We have an isolated ward, clinical oncology ward is isolated from the other hospital. That was so we was not involved in the COVID, but we saw every day that the patient passed away. That's what we think about helping them. I asked a pulmonologist, what's the reason for dying the patient with COVID? And he told me it's just by the bleeding in the lungs. I thought about it because we use radiation to stop bleeding. When a tumor is bleeding, we use radiation with the high dose per fraction. Just 1 or 2 fraction will stop the bleeding.
Why is that? What is the mechanism by which radiation stops bleeding?
Radiation has different effects. In my opinion, 2 days, radiation is a systemic therapy. Could be a systemic therapy, right? But it depends on the dose per fraction. Part of body that irradiated, how much body irradiated, they all affect the effects of radiotherapy on the patient. When you use a large fraction, prescribing large fraction of radiation, they usually make the vessels to be shrink, to
constrict them.
To constrict them, yes, to constrict them. And that's the reason for stopping bleeding.
I see.
But when you use with the lower dose per fraction, usually the vessels will repair themselves. when you use a large fraction, a severe inflammation will occur within the vessels, and they cause we say coagulation, stopping clotting the blood within the vessels, and that's why the bleeding will stop. But when you use a lower fraction, lower dose in each fraction, this kind of reaction was not occur.
I see. So what is the dose where this occurs? In grays, how many grays might be applied to cause this coagulation effect?
5-6 gray per fraction.
And what's a
Usually,
fraction? What is a fraction?
In cancer treatment, radiation will prescribe in different fractionation. For example, one fraction per day.
Treatment.
Yes. It's total dose will be divided in fractions, and each fraction maybe 1 fraction per day, maybe 2 fractions a day, prescribed to the patient for cancer treatment. For cancer, that's why the 30 fraction of 2 gray means 60 gray during 6 weeks.
Wow, that's a lot.
That's treat the cancer, for example, lung cancer. But nowadays, all things are changing. Now, cancer patients who have not metastasis and cannot be cured by surgery, or surgery is not possible, radiation with a fractionation of 18 gray, 12 grade, 16 grade, 18 grade, in 3 or 4 fraction will cure the patient.
Wow, so even higher.
We name it, yes, higher per
Wow.
fraction. We name it SBRT, stereotactic body radiotherapy, or fractionated SRS, stereotactic radiosurgery.
And this 18 gray fraction dose, what are the consequences of this? What are the negative side effects of going that high? I understand the patient is in bad shape, and so it's a last resort, but why have we not gone this high previously? What are the possible negative outcomes of going that high per fraction?
Radiation goal is to prescribe high dose to the target and spare air on targets. It's now possible, but in the past it was not possible to cure patient with such a fraction, such a high fraction per day. With the new technologies, as it's appear in the name, stereotactic. When with these new technologies, we can confirm the doses just around the tumor and spare 1 millimeter, 2 millimeter away all the tissues.
I see.
That's why
the new technology allows you to focus the dose into a smaller area.
Yes.
I see.
A smaller area and conform it. But in the past, we have
the volume as well. You're able to narrow it not just in terms of a cross-sectional area, but you're able to find a circle within the body, balloon within the body, and be able to target that balloon.
Yes, like this. That's why we can prescribe radiation in this regard. When you can spare more tissue, more normal tissue, you can prescribe more doses to the tumor. But whenever you cannot do this, for example, when the tumor is near the organ at risk, critical organs such as vessels, such as the brain, such as the when you are near the optic nerve, for example, you cannot prescribe that large doses.
Yes,
you have to bring down the doses, but more than the previous you can prescribe now.
And I'm sorry, I interrupted you before. You had met with a pulmonologist, and they had said the problem with COVID is the bleeding. And so you thought, well, I know how to stop bleeding with radiation. Please continue.
Yes, I thought about it that if we prescribe high doses for the place that the lung has and starting to study. We saw that the radiation has different effects. We saw that the low-dose radiation was used for pneumonia about 1 century ago with good results.
How did you know that? How did you find that piece of information?
I saw in the I saw in the publications. I searched for it.
You were able to just do an internet search through publications and journals, and it just appeared.
Yes, yes. Wow. Yes. We found in the journals, in the publications, that the radiation has a different effect with different doses. When we searching for the topics, we also know more and more about the mechanism of the ARDS in the COVID-19. And we actually, during time interested to the low-dose radiation, we saw previous studies and a good review in 2013 about the radiation, low-dose radiation effects. We saw that most people, about 30,000 patients treated with low-dose radiotherapy for arthritis. In Germany, every year, about 13,000 patients are treated with radiation, not with corticosteroid, not with aspirin, NSAID, other things.
And what is the dose that is applied in the arthritis case in Germany to 30,000 patients a year? What's the dose?
I think it's about 3 different doses, because there is no standard doses for this.
But what range does it sit in?
I think it's between 1, as you remember, I hope to be correct, as 1 to 4 gray, 1 to 4 grays.
So within the similar range as to what we're talking about here for treating COVID as well.
Yeah, that's why I think when they were searching for the plan, I hope to can help the patient, because we saw a catastrophic event in our wards, and when we decide to prepare a proposal for approval to the review board, we reached to a 0.7 gray as an optimal dose. Yes.
So less than 1 gray.
Yes, less than.
And that's all you're asking for to the review board. Yes, less than 1 gray.
Less than 1 gray. We also found some studies that use whole body 0.1 gray.
1/10 of
whole body. Whole body 0.1 gray for treating lymphoma, Hodgkin lymphoma.
Okay.
As a system, I told you before, radiation nowadays could be a systemic treatment.
Yeah. And how does that work? I know I've limited experience personally, but I've been to the dentist, and they have the device that goes and focuses on your mouth. What does a whole body machine look like? How do you apply a systemic dose of radiation?
It needs some special machines. We usually treat patient on the bed, under the head of the machine. But when we decide to treat patient whole body, we have to use patient in upright position away from the machine, and the machine head turn about 90 degrees with a more distance from the machine head, that you can focus all body in the irradiation field.
So it's just like a flashlight. If I were to hold a
Yes.
flashlight up against a wall, it would only occupy a few inches. But if I walk all the way back across the room, the flashlight will shine over a larger area, even at a lower level of illumination as well. Do you have to perform mathematical calculations to determine the dose as a function of distance from the machine?
Yes, I'm not a physicist, but it's a complicated calculation. It needs a complicated calculations, and our physicists have to design the machines and the calculation and the monitor unit that the machine will release for this treatment. I know experience with this, but I just imagine how can we treat patients whole body radiation with whole body radiation. Yes. I thought the 0.1 gray has prescribed to the Hodgkin lymphoma before the local treatment on the tumors. It low doses, very low doses, modulate the immune system of the body. And when we know about the mechanism of the COVID-19 cytokine storm, we decide to try half gray as a prescription to the lungs. We also decide.
Sorry, go ahead.
We also know that the effect of radiation on immune modulation will disappear after 48 or 72 hours, and we decide to add a additional dose after 72 hours if the clinicians, if the patient's physician request us.
If you see signs of the immune system still overacting after 72 hours, you want to modulate it, a dose of low dose radiation systemically across the whole body.
Yes.
And when did you first start this study? What month?
We are starting searching for the proposal and preparing the proposal to approve in our ethics committee about March. But the first patient was entered to our study, I think it's 20 of May, I think so.
And is it difficult to acquire patients for this type of study?
It's very, very difficult, especially in the first 5 patients that we presented. It was very difficult. More of our patients have a unwanted or unwarranted fear of the radiation. Also, a scientific community in our hospital also has this fear. They was not agree with us.
And I'm finding similar stories as what you're telling me across the world with other research scientists that are conducting similar studies. But my perspective is COVID, when you are in a hospital, is very serious. A lot of people die when they get brought to the hospital with COVID. And they should be very afraid of that, not just of radiation. And also, if 30,000 patients in Germany are getting even more radiation, and it's just to treat arthritis, it seems to me that that would calm people down and help reduce fears. What happened in your experience?
No, at first, nobody accept our tests. Nobody. I treated first 3 patients by myself. There was a fear. Yes, there was a fear of radiation for patients, and there was additional fear about the radiation oncology ward staff that bringing patients with COVID-19 into the wards and treat them. That's what the resist about the treatment. We accept about 40 patients to participate in our trials, and just 5 accept it. Just 5 patients accept it. Yes, I also asked about 5 our staff to help us to treat these patients, but just 1 accepted.
Why? Why was the staff who has dedicated
because
their life to medicine, not interested.
Yes, because in our wars, due to sanction, we have a shortage about most of the equipment.
Yes.
And the monitors and somehow drugs. That's why everybody thought that if I got COVID, what's happened for me? I think so.
Yeah.
But
and what about if there's a shortage of equipment for radiation? What about diagnostic equipment? Is it possible to use diagnostic equipment to get up to a half a gray dose?
Well, I have no experience with this machine, but no, I know that it would be very difficult because for the radiation machines, for radiation treatment machines, the 1 gray is a low dose, just as a blinking.
Yeah.
But for the imaging machines, it would be very high dose, and it need a pressure on the machines that are needed for diagnosis.
I see.
Yes, I think it's not possible. At least in our hospital, it's not possible.
So you were able to get 5 patients into your initial study. What was the results?
I think our study has some shortcomings, especially we started in the emergency situation. We could not give the best supportive care to our patients after radiation. That's what we discharged some patients that who be admitted, who should be on the ventilator or on the supervision, but the result was very amazing. Every patient after the first doses, after radiation therapy, the day after the radiation, all patients, I saw all patients after the radiation, and all have different face. They were very relaxed, very nice. But the complementary treatments was not effective, was not available. Sometimes not available. We need our beds for more complicated patients. But I think it was very effective. After 3 patients, I told my wife, if I got COVID-19 pneumonia, my first choice would be radiotherapy.
Yeah. So you're saying you got the worst of the patients, the most dire of cases,
Yeah.
no support to help, in any treatment, you need additional resources and support to help nurture a patient. And even given these horrible circumstances, you saw incredible results from the radiation
Yes.
in a short period of time, too.
Yes. We achieved a clinical response of about 80% in the first 5 patients.
80% effectiveness in the first 5 patients you ever tried this on. And you hadn't even figured out the right tuning, the right amount of dose, the right time, the right post-treatment, and still 80% effectiveness.
Yes.
Amazing.
We achieved 80% response, but response was defined in different way in different studies. But we saw the oxygen saturation increased, inflammatory markers decreased, and for first 5 patients, we achieved about 80% response. When we added 5 more patients, we achieved a response about the 66%, a bit lower.
And what do you think accounts for that? I mean, I know it's low numbers, and so it could be.
When we start to accrue the patient to the trial, we saw the trials of Imroy in a preprint publication.
Ameri. Emory University.
They used 1.5 grade with dramatic response, And that's why we knew that the lower doses is better to control cytokine storm, to modulate immune response. In preprint version, we decide to increase doses. We decided to and treated 4 less patients with 1 gray. With 1 gray. The study is very small, but show us that the half gray may be better than 1 gray.
Yes.
The results show us these differences that we thought from the first. Lower doses is more effective for modulation of immune system.
I see. And so where do your studies stand now? Where can you, now that you've done 10 total patients, are you trying to increase the patient count beyond 10?
Yes, we asked our ethical committee to let us to conduct this study with the more patients. They accept, but the resources don't let us to go ahead. We had 2 machines in our wards for radiation. These machines work from the 7 a.m. until 9 p.m. And we have a lot of problem with the services. This machine should be serviced, should be maintained. And there is a lot of shortage about the accessories of this system. That's why I haven't give the agreement of our wards chief. That's why we are trying to conduct a more and bigger study with different doses. We are interested in define the better doses for this kind of patient, but I don't know I can succeed or not.
So, but it seems to me that while it might seem in the short term that this treatment would consume resources, in the long term, on net across the whole country, it could save many resources, because think of all the people that would not have to occupy hospital beds, would not have to take drugs, would not have to take doctors' time if it was as quick as the blink of a button from one of these radiation machines.
Yes, it's my I think also like you, but somebody else should be decide about it. Make them happy with our mind is very difficult. Yeah. It's very difficult because this kind of trial, this kind of study have not been occurred before. Yeah. Another discipline had the patients, and the treatment will be delivered with other disciplines. You know, that's why we cannot bring them in the table for this kind of study. We ask also for the earlier stage of the disease, or for patients who just are very, very in good condition, and they can go to the radiation ward by walk and receive the radiation to decrease the hospital beds occupations.
Yes.
We also write a proposal for this kind of the treatment, but we are still on queue to approve it.
And tell me though, what access to resources do you have, not officially, but unofficially, beyond your hospital? For instance, are you part of a society with other radiation oncologists across Iran where you can discuss learnings and call them up and say, here's what happened with my equipment. Maybe in your hospital, you should try it with your equipment. Does this type of collaboration occur?
Yes. Overall, we had a shortage of the radiation machines due to sanction.
in the whole country.
Over the country, not just in our hospital, over the country.
And I can understand if there's a shortage of equipment, how people can't see, you know, all of the angles and all of the bigger picture, and how they're just focused on their short-term and more immediate concerns. Which brings me back to my previous question. If the goal is to apply a half a gray dose, can't we look at other types of equipment and just run them for a longer period of time, like a diagnostic chest X-ray, or even dental equipment, and just leave it on for 15 minutes, perhaps, instead of a blink of time, to still apply that half gray dose, and perhaps let people, even in the private sector, apply this therapy off protocol to start getting more results and save lives?
I think is not possible. I think the effects of radiation depends on the doses, also dose rates. You can prescribe half gray in 1 second. Also, you can prescribe half gray in half hours.
Yes.
They have different effects.
I see. Now I understand. Okay.
Yeah, they have different effects. You can prescribe radiation half gray to just one tooth, and you can prescribe half gray to whole body. If you prescribe 8 gray to total body, 8 gray to total body, we have seen, we would see the acute radiation syndrome.
Acute
patient
syndrome, yes.
Yes. And patient usually die within 48 hours.
Yeah, yeah.
But if you prescribe 8 gray to just limited era, nothing happened. After 10 years, 5 years, you can see just a scar of this treatment.
I see. So there'll be like a local burn almost, because it is energy being imparted, but it doesn't do damage to the entire system.
Yes, system.
I see. Yes, I see.
Yeah.
So what you're saying is there's an art, there's a science to the application of radiation, and there are different dials, and one dial is time, another dial is area, and the product of these different dials creates a whole range of effects on the body. And so there are maybe 1,000 actually different types of radiation treatment, even with the same radiation, based on how much you apply, how long you apply, and over what area you apply.
Yeah, we usually use this. I told before that when we are near the critical organs, we adjust the doses per fraction. We can adjust the time between doses, 1 day, 2 days, 3 days, between 2 prescription of doses that help us to save normal tissues.
Yes.
Radiation affect all cells in the body and also micro environment around the body. For example, vessels, proteins, cytokines, mRNA, DNA, all of these are affected by the radiation, and all are affected in different way by different doses. We don't know about the effect of radiation. I think radiation is all treatment for all disease. All treatment for all disease, but we just know about the side effects.
Yeah.
It's more than corticosteroid. We know about the side effects of radiation more than remdesivir, because it's old. We know everything about the side effect, but about the effects, it was suppressed after the antibiotics for inflammatory disease.
Wow.
You know, that's why we need more and more about radiation. I told at first the radiation now, I think, is a systemic treatment. Nowadays, the more exciting treatment for cancer nowadays is immunotherapy. Immunotherapy, what is a treatment that modulates the interaction between tumor and the immune system. The interaction, just this. We use chemotherapy. Chemotherapy is a cytotoxic and kill the cells. But the immunomodulation, immunotherapy, just modulate the interaction between cells and immunes, cancer cells and immune cells. And I think radiation could be a replace for this immunotherapy.
And it seems to me, by many of the people that I've met, that it's oncologists who have the most experience with radiation. Are there other doctors around the world, like immunologists, that are now also developing experience with radiation, or is it still mostly a discipline of oncologists?
No, most of is related to the oncologist.
Yeah.
Oncologist, I told you that we have clinical oncologists that prescribe systemic treatment and radiation. Yeah. And also we have medical oncologists that just prescribe drugs. And we have also radiation oncologists that just prescribe radiation, not systemic treatment.
It seems to me, though, that based on what we understand of radiation's effect on inflammation, which is an immunological response, both in the German case, in the old case of viral pneumonia, and many other cases where even in oncology, post-cancer treatments, where it's used to tamper the immune response and tamper inflammation, or in your blood clotting example, it seems that the applications of radiation are broader than just oncology, and it should be partially a discipline of immunologists. It surprises me that you don't have immunological researchers around the world, around the whole world, that are desperate to try studies with radiation to see how it might impact their field and move their field forward.
Yes, you're right. Completely. Immunologists likes radiation 2 days because radiation with a high dose per fraction, as we explained for you for lung cancer, can produce new antigens, different way. Yes, in the high dose fraction, suppress the immune system. And excite the immune system and cause inflammation. But at the same time, it could make new antigens. Cancer has some antigen that is a foreign antigen to the body. And immune system will suppress by the cancer cells. When you use high dose radiation, you make new antigen on the cancer cells, and the immune system will stimulate against this new antigen and attack them.
I see.
That's why 2 days we use radiation, high dose radiation with immunotherapy.
Fascinating. So just to paraphrase, the cancer has a mechanism to combat the immune system normally. It's able to suppress the immune system. It does things. It has its own way of hurting your body. So we need to find a way sometimes to supercharge the body's natural protective forces in order to beat back the cancer's forces.
Absolutely.
It's like a war between the cancer and your immune system. And the radiation is a signal to the immune system to gear up and fight the cancer.
Yes, exactly. I told you, we can use low dose whole body radiation to modulate the immune system to be activated, and use high dose local radiation to the tumor to make new antigen.
And so as we wrap up here, maybe just kind of tell me about the future of what you think might happen with COVID in your country with this treatment. Do you think that some of these shortcomings of the equipment might be overcome, or that there might be more international recognition? Or do we think this is the best we can do for this time period, and it's just going to take a long time to bring this therapy into practice?
I think there is some barrier for this hypothesis, because The shortage of the equipment in our country is just one reason. There are another reasons. We know radiation was suppressed due to the Rockefeller Foundation decision. They decide about the side effects of radiation. They bring the acceptable doses lower and lower.
Yeah.
But the effect of radiation is more than corticosteroid, I think, more than remdesivir, more than every other drugs. Dexamethasone has been approved as a treatment for this in the large trials.
Yeah.
Recovery trials. Yes. But when you see most of patients stay in hospital after 20 days.
Yeah.
But about radiation, no, radiation has no support.
Yeah.
But this is the second part. And the third one, if the equipment provided in our country or other parts of the world, the interdisciplinary connection is very difficult. We don't have such kind of the trials, and it's very difficult. I hope that
between radiation oncologists, immunologists,
and
pulmonologists,
other specialists.
Yeah.
Yes. I hope that if we could conduct a more larger trials, randomized trials, maybe we can go ahead for designing a special machine for this kind of treatments.
Yeah.
That no complicated like accelerators that we use for the treatment of cancer. I told you we need to confirm doses to the tumor. Yeah. But for this kind of treatment, we can use a more simple machines and will design for this purpose.
Yes. And I guess maybe one last thing, you're able to, a lot of people are very closed-minded about the application of radiation, but you're very open-minded to it. What separates you? How come you're able to try new things where some of your colleagues might be more conservative and stuck in the old ways?
I should ask from them. I don't know, but I think I saw a lot of this.
Yeah,
I have to do something. What I can do, I bought about 6 full monitor for our hospital from my pocket. That was the first things I did. After that, I decided to do other things, and that's why my work. That's what my work. I don't know why the other people thinks, how they thinks. Especially, we had pulmonologists, we have ICU caremen, and other specialties in our team, but they are not deciding. The people who decide about the radiation treatment should be open-minded. It needs work and work. If we could have the results of a large randomized trial, they help us to convince them that help us for treating patients with this kind of treatment, radiation.
Dr. Ameri, thank you so much for the work that you've done so far. Thank you for taking the time to explain it to me and my audience, and we wish you the best of luck in the future as well.
Thank you for inviting me for this interesting talk. Thank you. Thank you very much.
Okay. Bye-bye.
Thank you. Bye-bye.
And initiate at least a new approach to the many difficult problems that must be solved in both private and public conversation if the world is to shake off the inertia imposed by fear and is to make positive progress toward peace.